We look at coronary artery disease, also called coronary heart disease, ischemic heart disease, coronary artery syndrome, etc., etc. So this is a group of conditions that affect the coronary blood vessels that supply blood to the myocardium, the heart itself. More than 90% of myocardial ischemia cases are due to atherosclerosis. So there is atherosclerosis within the coronary arteries. There is gradual narrowing of the lumen, which causes ischemia of the myocardium. As you can imagine, initially at rest, even though there is partial blockage of the coronary artery, there wouldn't be any signs or symptoms. But when the patient will start to do some exercise, when the heart rate goes up, myocardial oxygen demand increases, the partially occluded coronary artery will not be able to meet the demands. And then the patient will start having the signs and symptoms of ischemia. When this occlusion is complete, this is when the death of myocardial tissue will occur, which is known as infarction. In layman terms, it is known as heart attack. What are the risk factors for coronary heart disease? There are three groups, actually two major groups: conventional risk factors and non-conventional or non-traditional risk factors. Within the traditional ones or conventional ones, there are two further categories: modifiable, non-modifiable. Now, non-modifiable are the ones which you can't modify, right? You can't change patient's age. You can't change patient's sex. You can't change family history. So these are non-modifiable. Modifiable ones are dyslipidemia, okay, hypertension, smoking, insulin resistance, diabetes, obesity, mainly the central obesity, abdominal obesity, and sedentary lifestyle. So these are modifiable risk factors for coronary heart disease. And these risk factors are very common to risk factors of atherosclerosis, because more than 90% of cases of coronary heart disease are due to atherosclerosis of coronary arteries. Now, there are new factors which are known as inflammatory factors, expedite the process of disease. Obesity, sedentary lifestyle, and metabolic syndrome. And someone who has this has very high risk of developing coronary heart disease. And almost 30% of Australian adults are estimated to have some form of metabolic syndrome. So it is very common. Abdominal obesity out of these has strongest link with coronary heart disease. Physical activity and weight loss protect against it. What else? I told you one of the newer addition to the risk factors are inflammatory markers, inflammatory factors. What are those? TNF alpha, interferon gamma, C-reactive proteins. Now, statins are thought to be cardioprotective, partly due to an anti-inflammatory effect. So in addition to lowering the cholesterol levels in the blood, they also have anti-inflammatory effect, which contributes to their ability to reduce the risk of cardiovascular events. How do you prevent coronary heart disease? So your target is to keep the LDLs below 1.8 millimoles per liter and to keep the HDLs above 1 millimoles per liter. Low triglycerides, low VLDL, low lipoprotein A. Plus, you limit unhealthy fats in their diet. What are unhealthy fats? So trans fats and saturated fats are unhealthy fats. They are more atherogenic. On the other hand, unsaturated fats, omega-3 and omega-6 fatty acids, are healthier and partly protective. Okay, so this is the dietary advice that you'll provide to patients who are prone to develop coronary heart disease. Now, if there is development of coronary heart disease, as I was telling you earlier, initially there'll be myocardial ischemia. There's partial blockage of blood flow. Narrowing of a major coronary artery by more than 50% would lead to ischemia, especially during exercise. At rest, it may be able to meet the oxygen demands of the myocardium. There'll be no signs, no symptoms, no ischemia. And atherosclerosis is the most common cause. I think we've emphasized this so many times already. Within 10 seconds of occlusion, anaerobic respiration within the myocardial cells forms lactic acid. Cells are viable for approximately 20 minutes. If within 20 minutes, if these myocardial cells receive enough oxygen, they will recover. But if they don't receive for 20 minutes enough oxygen, they will die. So this is the window of opportunity, I should say. If ischemia continues, so if it's more than 20 minutes, then the cells will die, necrosis. Okay, inflammation will ensue as a result. There'll be formation of granulation tissue, ultimately scarring. Angina is the clinical presentation of myocardial ischemia. For 3 to 5 minutes, patient will feel this chest pain or uneasiness with no permanent damage. It's usually substernal, central. It could be heaviness or pressure, or in some patients could be severe pain. So it differs in presentation from patient to patient. So with activity, pain will come, and if the patient sits down, the pain will go away within a couple of minutes. Myocardial ischemia does not always cause overt symptoms, especially in the elderly. So sometimes you could have silent ischemia. Okay, patient could just say, I felt, fatigued. There was a bit of breathlessness or a feeling of unease. That's it. There won't be any pain. Dyspnea may occur, and there are ECG changes, but these ECG changes are transient. If you do ECG during the pain, there'll be changes. If ECG is done after the pain is gone, you won't find anything. ECG will be perfectly normal. Angina can be divided into 3 major types. Stable angina is the commonest one, as I was explaining to you in the previous slide. Due to gradual luminal narrowing and hardening of vessel wall, reducing ability to dilate in response to increased myocardial demand during stress or exercise. This is stable angina. And usually, the patient will tell you exactly how much exercise they have to do before the pain comes. Unstable angina comes under acute coronary syndrome, and I'll explain to you later. It's not related to activity. It can come and stay for longer duration, the pain. Prinzmetal angina is a rare type of angina. This is due to vasospasm. So the coronary artery undergoes vasospasm. It becomes narrow. Okay, it has no link to physical activity. It can occur sometimes during sleep, during the REM type sleep. Atherosclerosis may or may not be present. How do you evaluate myocardial ischemia? So between events, there'll be no signs or symptoms. In chronic conditions, rapid pulse or extra heart sound may occur, but this is very, very rare. Xanthelasma or arcus senilis associated with dyslipidemia. So there are certain findings that you can see. These are fat depositions under the skin. So you can see in some people. Arcus senilis is a whitish line around the black of the eye. Okay, also present in people who have dyslipidemia. So this can give you a clue of dyslipidemia, basically. Okay, ECG may show transient, which means only during the episode. Transient ST changes and T wave inversion due to subendocardial ischemia. ST elevation is seen in Prinzmetal's angina. So ST elevation is usually seen in myocardial infarction, as I will explain later. So Prinzmetals can show you ST elevation, but usually in stable angina, you will have ST depression. Angiography is useful. It will tell you, it will show you if there is any narrowing of the coronary artery. Yeah. So this is normal ECG. Remember, P wave, QRS complex, and T wave. In between, you have these straight lines. So during ischemia, the cells will conduct electricity in a different way than in a normal state. So what you see here is ST segment, from S to T, ST segment depression. It goes below the baseline. See here, very clearly, there is ST segment depression. Sometimes you can have T wave inversion. T wave becomes the opposite. Now, ST segment elevation is not usually seen in angina, but it could be seen in Prinzmetal's angina. How do you manage myocardial ischemia? Your main aim is to increase coronary perfusion and decrease myocardial workload. So you intervene by decreasing the work of heart, by decreasing blood pressure, heart rate, contractility, and diastolic volume, anything that can reduce the workload on the heart. You decrease blood clot formation, because in most cases it is due to atherosclerosis. You don't want thrombus to form in these patients, so you try to prevent thrombus formation. And if there is dyslipidemia, then you treat that. You can give statins or other drugs if needed, right? Make sense? Now moving on from ischemia, let's move on to the next stage now, which is acute coronary syndrome. So we'll talk about myocardial infarction now. When you look at ECG, if there is ST elevation, okay, this is clearly myocardial infarction. But there could also be non-ST elevation, acute coronary syndrome. What you do, you give some time and you evaluate ECG again, and you also measure biomarkers. There are certain cardiac enzymes that you can measure in the blood. If those markers are present, those enzymes are present in the blood, it means myocardial cells have died. They have undergone necrosis. Only then those enzymes are released into the blood when the cells rupture. So when you have presence of those enzymes in the blood, it's a confirmation of myocardial ischemia, myocardial necrosis or infarction. Okay. So over time, if the myonecrosis is confirmed, so you have ST elevation. This is ST elevation myocardial infarction. Okay. If you have ST elevation myocardial infarction, but the enzymes are not raised, then this is unstable angina. Okay. Although you saw ST elevation, but when you measured enzymes, they were not raised. So this is unstable angina. Okay. If there is no ST elevation, but enzymes are raised, this is non-ST elevation myocardial infarction. In the past, the diagnosis was based mainly on ECG. Now it is based on ECG plus cardiac enzymes. Now, acute coronary syndrome, let's try to understand this in more depth. So, atherosclerotic plaque partially obstructs coronary blood flow. Okay. If it is a stable plaque, same size, it would lead to stable angina. If the plaque is unstable, or if there is ulceration, or it gets ruptured, what will happen now? Okay, you could have formation of thrombus on top of it. Okay, this would lead to acute coronary syndrome. Even without formation of thrombus, the rupture of this plaque and ulceration can also lead to acute coronary syndrome. Again, there would be transient ischemia. So this is unstable angina. But this ischemia can transform into, if it is sustained, it can transform into myocardial infarction. Okay. So, and as a result of myocardial infarction, their immediate effect is myocardial inflammation and necrosis. Long-term effects are myocardial remodeling. And of course, this is a very undesirable end result. Okay, but it is possible as a result of, if large areas of myocardium are affected, it could lead to death. It makes sense now? So unstable angina is basically in the progression towards infarction. Okay, how do you manage acute coronary syndrome? Now the guidelines The latest guidelines are from 2016. So the key evidence-based recommendations include that the initial assessment should involve a 12-lead ECG with clinical interpretation within 10 minutes of first presentation. Care is guided by a suspected ACS assessment protocol. Then you do this enzyme, cardiac-specific troponin. Recommendations for long-term management include dual antiplatelet therapy with aspirin, and you can also give these statins. The highest tolerated dose of statin should be initiated and continued indefinitely. Of course, lifestyle education, cardiac rehabilitation if there are complications, chest pain action plans, also part of long-term therapy. So these guidelines keep changing depending upon the latest research and drugs which are becoming available. So always check the latest guidelines on heartfoundation.org.au. Now, let's talk a little bit about acute myocardial infarction. Infarction means there is necrosis and the muscle cells have died. Yep. There could be subendocardial myocardial infarction, which means it is only affecting small area under the endocardium. Usually this is non-ST elevation myocardial infarction. So that myocardial infarction, remember, where there was no ST elevation, but the enzymes were raised, that is usually subendocardial MI. Transmural is ST elevation MI, where the necrosis is involving the whole thickness of the myocardium. Okay, transmural. So ECG changes appear after half to 1 minute of hypoxia, so very quickly. Anaerobic respiration causes a decrease in pH. Necrotic events occur. These ions are released. Contractility of this area will immediately decrease. Okay. At the same time, angiotensin II is released and contributes to pathogenesis. When there is myocardial infarction, the heart is not doing its job very well. Kidneys will sense it, release renin, so ultimately you have angiotensin II. When this comes in, okay, catecholamines release, which will cause further coronary artery spasm, vasoconstriction, fluid retention. This is a long-term effect, smooth muscle proliferation, myocyte growth and fibrous formation leading to myocardial remodeling. Okay, so these two are long-term effects. These three are immediate effects. Dead myocytes release troponin and few other enzymes which can be detected. Ejection fraction will decrease and diastolic volume will increase. Venous pressure will also increase. There will be venous pooling. Congestion occurs. If it is left-sided infarction, then pulmonary. If right-sided, then systemic congestion will occur. Within 24 hours, leukocytes will come there. They will start removing the necrotic tissue and scar tissue will start to form. By 10 to 14 days, the newly formed tissue is still weak and susceptible to injury. At 6 weeks, scar tissue is usually strong, but lacks ability to contract or conduct impulses. Usually pain similar to angina, but the pain is much more intense in acute myocardial infarction. It may be silent in elderly or those with diabetes mellitus. So people who have diabetes mellitus, you have to specially educate them on danger signs of angina or myocardial infarction because they may not feel any pain. They will just feel some discomfort, maybe some sweating, that's it. Okay. Peripheral vasoconstriction, diaphoresis, ingestion is common, indigestion, sorry. Nausea, vomiting may occur. BP initially will drop, but when the sympathetic nervous system kicks in, the BP will actually go up and also the heart rate to compensate for the decreasing cardiac output. Abnormal heart sounds can be heard if there is ventricular dysfunction. Pericardial friction rub may occur if there is inflammation. Dullness in lung percussion and inspiratory crackles from pulmonary congestion may occur. So if there is failure of the left side, back pressure, into the pulmonary circulation, then you can hear crackles when you auscultate the rest of the lung fields. Okay, make sense? Complications are related to the site and severity of necrosis, pre-MI, patient health, and of course, medical intervention. Sudden death may occur if the area involved is too large. History, physical exam, ECG, serum biomarkers, mainly troponin I and troponin T can be used. ECG, characteristic Q waves may develop in ECG. You can also look at blood report. So if there is inflammation, you will have increased neutrophils, leukocytosis, elevated ESR, C-reactive proteins, so on and so forth. And on ECG, now if infarction is here, you're looking at ECG. Normal ECG is like this, right? Ischemia is ST depression, T wave inversion. All right. And during the injury, you will have ST elevation. Following the injury, when the cells have died, you will have a very prominent Q wave. See, the Q wave is very small usually, Q, R, S, right? The Q wave becomes very prominent. So in infarction, the Q wave becomes very prominent. Initial change would be ST elevation, then there would be Q wave prominence. This Q wave may stay for life. So presence of Q wave can actually give you an idea about infarction in the past. So this is just to show you how this infarction looks like. The thrombus here, and this whole myocardium has died as a result. This is the cavity of the left ventricle. And this ventricle is already hypertrophied. So this patient probably had hypertension for many, many years. Left ventricle is already hypertrophied. And then on top of it, there is now atherosclerosis, formation of thrombus, and this whole myocardium is dead. Now, this area has lost the ability to contract, right? When there is increased pressure in the left ventricle during systole, right? When rest of the ventricular wall is contracting, trying to push the blood out, what will happen to this part? It has lost the ability to contract. It will actually bulge outwards because of pressure building inside, right? So you will have paradoxical movement of this part of the ventricular wall. When the rest of the ventricle is contracting, moving inwards, this area will be bulging outwards because of its lack of ability to contract. So it could lead to, if the area is large, can lead to severe decrease in stroke volume and cardiac output ultimately. Make sense? Now, how do you manage? First of all, you admit the patient into coronary care unit because you will need regular monitoring. Oxygen should be given. Aspirin could be given. Sublingual glyceryl nitrate. Usually the pain of myocardial infarction is very, very severe, so morphine can be given. The pain of myocardial infarction is described as impending doom. It's so severe, so morphine could be given. Glyceryl nitrate is a venodilator. It dilates the veins, so it reduces venous return, reduces the workload on the heart. So heart gets a bit of rest, okay? If patient came to you and not much time has passed since the thrombus was formed, you can give thrombolytic agents, okay? You can give thrombolytic agents to dissolve the thrombus. If myocardial cells have already died, there's no point in giving thrombolytics because they have a lot of side effects. You only give them if you can salvage some blood flow to the myocardium and save some cells from dying. You can do coronary angioplasty, okay? Monitor cardiac rhythms. In the initial phase of myocardial infarction, cardiac arrhythmias are very common. The most common cause of death in the acute phase of myocardial infarction is cardiac arrhythmias. So you watch for cardiac rhythm, keep measuring the enzymes to see the damage to myocardial cells. You can give ACE inhibitors. You can also give beta blockers. If patient is in shock, if the cardiac output has fallen to the level that is unable to meet demands of the body, patient is in circulatory shock, then patient may need aggressive fluid resuscitation, inotrope administration, and possibly emergency surgery.